further ado, I'm pleased to introduce our first speaker, Dr. Mitchel Williams, who is a pediatric epileptologist and neuroimmunologist from Children's Hospital of Michigan. So thank you, Dr. Williams, for being here tonight, and floor is yours. So you can share your screen and we'll get started.
Okay, excellent. So thank you everyone for inviting me to speak today, being one of the panelists for the discussion tonight. So I will be starting with a brief overall presentation on inflammation and the role of the immune system, especially in regards to the central nervous system. And then I'll go into more of the pediatric perspective on inflammatory epilepsies and autoimmune epilepsies. I have about 30 minutes or so that I'll be presenting this. So obviously there'll likely be some additional questions at the end after my fellow panelists' presentation on the adult roles of inflammation and epilepsy. So first, I just wanted to make sure I have no relevant disclosures, financial or otherwise, relevant to this presentation. And it's also important to note that I will be discussing some off-label use of FDA-approved therapies. It's important to note that, especially in pediatrics, that there is a limited number of actual controlled clinical trials done in these therapies. Most are open-labeled studies and small case series experiences on evidence-based medicine for therapies that will be discussed tonight. So first, it's important to know really kind of how the immune system is structured, because it's really relevant to especially autoimmune forms of epilepsy. Typically, it's composed of two interdependent portions: the innate immune system and the adaptive immune system. So when we're looking at these two, they're interconnected, and there's often a lot of overlap between the two, both in the cells that are involved and in the molecules and triggers that are involved with both sides of the immune system. The innate immune system as it's described, it doesn't require advanced training or immunization to develop it. It involves different cell types that are able to quickly address infection. It's a very non-specific, generalized system that responds to pathogens, damage, and other and to cells that are in a stressed state. They're typically thought of as our first responders, and they respond to the acute inflammation that is present. Its duration is usually shorter than that of the adaptive immune system. Over time, with exposure to a pathogen or other type of target, the adaptive system then comes into play. That's why there's a bit of a lag time. Certain cells have to be called to the site of injury or inflammation, start recognizing a foreign antigen, which is some type of molecule or substance that then the immune system is then trained to recognize. It's also the term used as vaccination, right? Usually this develops a memory to that foreign entity or antigen, which can last months to years. But it often depends on the initial inflammation and response by the organism's immune system. Now, inflammation is a normal part of our body's reaction to usually a form of injury or infection. Typically, what we refer to as healthy inflammation happens in order to get a appropriate response from the body to address any signs of infection or injury. This inflammation releases different types of molecules and cytokines and other cell-mediated processes to kind of pull in all necessary cellular equipment to either start addressing the infection or the toxin, or to identify the injury and start the normal healing process. Often this is a self-limited process until the infection or inflammation from the injury is resolved and the healing process is finished. then you get regain of homeostasis or regular cell function in that area. However, unfortunately, due to either a very strong infection or body's immune response to this, there can be excessive inflammation. A lot of times this inflammation, when it becomes excessive, can cause an unusual tissue response, especially if it's in the central nervous system. It can cause significant dysfunction and damage. If this continues to happen and there's failure of the body system to regain homeostasis, or that normal ending of the inflammatory response, you then develop a chronic inflammatory disease. Fortunately, majority of inflammatory responses are what we call self-limited, meaning that there is an endpoint to them. But unfortunately, for other conditions, they can be excessive and chronic in nature. Other factors to take into account when we're talking about the nervous system and the immune system. The brain and the central nervous system is what scientists refer as a privileged region of the body, meaning that the immune system has a limited access to the central nervous system. And that's important because having an excessive immune response or inflammatory response in the central nervous system can cause significant damage, especially if it's not under control. So one of the mechanisms that has developed in the human brain is what is referred to as the blood-brain barrier. This barrier forms tight connections between cells that align blood vessels that go serve and transmit nutrients and oxygen to the brain. And only certain fluids, small molecules, and immune cells are able to get through this blood-brain barrier. Now, in autoimmune disease or in severe inflammation, there can be compromise of this blood-brain barrier, which can lead to more issues related to unintended access of certain cells into the central nervous system that can then cause further dysregulation or damage. The blood-brain barrier is composed of several different types of cells. The endothelial cells, which are the cells that actually make up the wall of the blood vessel. The basement membrane, which is the connective tissue that surrounds these blood vessels. And it's also involved of other cells that surround this, including neurons, astrocytes that project these little, what we call foot processes, which help make up the blood-brain barrier. Now, what is important to note is that injury happens directly or indirectly to the central nervous system can lead to a cascade of effects that are part of normal healing, but also can be abnormal inflammation related to the injury. So these can be, and that will be expanded on later in the second portion of our talk tonight, trauma, stroke, direct infections of the central nervous system, seizures for other causes, not necessarily related to epilepsy, as well as some unknown factors, which may include other genetic factors. This type of inflammation in discrete regions in the brain often cause, increased release of cytokines, which then, and other inflammatory mediators, which bring in other types of immune-mediated cells, which are usually supposed to respond to the local disturbance, either the infection or areas where tissue has been damaged or destroyed. This process can be in excess, leading to abnormal gliosis, which is, you can think of that as an abnormal scarring effect in the brain, as well as abnormal neurogenesis, reorganization in the area, which is in basically trying to adapt. But because of all this and the neuronal death, so the death of these brain cells and altered connectivity, there's also increased excitability in this region, which leads to this, the term we call epileptogenesis, which is the generation of a new epilepsy focus. And because of this process, which is often very much mediated by inflammation, can then lead to an acquired form of epilepsy due to these type of injuries. Now, there can be other causes of inflammation. These are some of the more common neurological disorders where inflammation either plays a direct or indirect role in the epilepsy that's associated with them or the epileptogenesis. Febrile seizures are a very common pediatric form of seizures. It does not represent actually epilepsy, but it occurs in high rates in children between the age of 6 months and 5 years of age. It's typically associated with infection, which triggers release of these inflammatory mediators called cytokines. These cytokines trigger fever. At the same time, for particular reasons that are usually unique to the individual, they can trigger seizures as well. Now, these are usually self-limited, meaning that as long as there's no further fever in these individuals with febrile seizures, they should not develop any further seizures. But as we know, in that age in pediatrics, fevers and febrile illnesses are a very common experience. However, it is self-limited, meaning that these children do grow out of these risks for these febrile seizures. But again, it's unknown reason why humans have developed this kind of response to infection in the release of these normally released chemicals to address the infection, but also causing neurological dysfunction. Another but less common neurological condition which affects multiple body organ systems is a genetic condition called tuberous sclerosis, or also referred to as tuberous sclerosis complex. It involves abnormal regulation of cell regulation and inflammation in the brain. And more recently, in the last decade, it's been recognized that these inflammatory pathways that are involved related to the specific two types of mutations that cause this disease very much influence these areas where epileptogenic focuses start. Again, because of that, new targets have been developed over the last period of time, including those that may help with secondary tumor or masses that occur in this condition, and also to treat potential new targets for epilepsy and inflammation in these patients. Another type of epileptic syndrome called infantile spasms, which can be a very devastating epileptic encephalopathy that develops in young infants, usually between the age onset is usually around about, on average, 6 months. It is a epileptic encephalopathy that causes significant regression in many and often neurodevelopmental outcomes, if the spasms are not treated in time, can be very poor. Even when treated, many times the neurodevelopmental outcomes are poor in these children. Inflammation is an important role in this, as it's identified that if in brain regions that were previously not thought to be involved in the type of seizures now show that there's evidence that there's an inflammatory component. One of the mainstay treatments of these type of epileptic spasms is ACTH, which is a very powerful steroid or corticosteroid that's produced naturally by the body, but we give large amounts of exogenous, meaning outside sources of this, which for a lot of patients, anywhere from between 60 to 80% of patients will put this form of epilepsy in remission. So we're recognizing that there's more forms of underlying epilepsy where inflammation is a very significant mediator of the disease course. Even in those that have no form of autoimmune epilepsy or an inflammatory related epilepsy, those with epilepsy, it's been long recognized, and in many families would be able to identify with this, that even during normal infection, the seizure focus or the seizure threshold seems to be reduced, meaning that even despite adequately dosing an anti-epileptic medication, when a child develops a febrile illness, often breakthrough seizures can be seen during that time. Now, a very specific and very devastating form of fever-related epileptic encephalopathy is a syndrome called febrile infection-related epilepsy syndrome, or FIRES. In the past, it's had many synonyms for it. Just referring to basically the nature that is associated with infection with apparent encephalopathy, hard to control seizures, and poor post event outcomes with refractory or hard to treat epilepsy and neurodevelopmental impairments. This is an important condition because it's relatively rare, but when it's encountered, it can be devastating. It's very severe. Typically, a lot of the effects that happen at the initiation of it are reversible, meaning that there's permanent changes that happen in the brain. Usually these kids present after a period of 1 to 2 days of a sudden onset of a febrile illness, fairly innocuous starting. However, start with increasing evidence of seizure activity, either cluster seizures or going into what we refer to as status epilepticus, which is a seizure which is not terminating or stopping on its own. Many times these are what we call refractory status epilepticus, which means despite administering many different types of medication, including IV anti-epileptics and other anesthetic agents to hopefully put them into a basically an induced coma, often are not successful in stopping these seizures. There is a fairly high, unfortunately, mortality rate for those that are unable to be, seizures are unable to be stopped. Usually, we cannot identify a clear cause, or what we call etiology, to these. Brain biopsies in the past have not shown any signs of direct inflammation of these nerve cells. However, we know it is immune mediated because some of the treatments for this are immune mediated interventions. Eventually, for those that eventually their seizures stop for a period of time, they're often left with significant neuropsychological impairments that are present right from the get-go. And often they subsequently have epilepsy, which is hard to control. So because this is a fairly sporadic and extremely rare condition, not a lot's known about it. What we do know is that it can occur in any age child, essentially, except infants. The mean age is usually about 8 years of age. There's usually never a previous medical history, meaning that there's not any evidence of seizures. Sometimes some case reports have identified a history of febrile seizures, but overall there is no other medical history, and these children were developmentally normal up until that point. Again, family history is typically negative for any evidence of familial forms of epilepsy, any previous family members who had a similar presentation of FIRES, or other types of autoimmune disease, which may put the individual at a genetic risk for developing autoimmune disease, including autoimmune neurological disorders. Infectious and metabolic and genetic workups are typically negative or non-informative, showing non-specific findings. Rarely cases of identifying what we term as autoantibodies, meaning antibodies that are directed against a self protein, or what we call antigen, may be identified, but that's not usually the case and is often not felt to be causative of the condition. Because of this, these conditions are often, these inflammatory epilepsies, especially these epileptic encephalopathies and refractory status epilepticus, are very hard to treat. Now, other forms of immune-mediated epilepsies show up as autoimmune encephalitis or autoimmune epilepsy. This has been increasingly recognized in children as discrete entities. And this has been because of over the last 2 decades, there's been expansion of new biomarkers for these conditions, which are usually these autoantibodies, which can then be clinically screened for in an individual to identify these autoimmune epilepsy conditions. Now, because the underlying abnormality or pathophysiology is immune driven, management of these cases and treatment is directed at the modulation of the abnormal immune response against these self-antigens, which are causing dysfunction and damage. Now, when the body creates these autoantibodies, it can be through 2 approaches in the immune system. One can be due to a B cell mediated process. So our B cells are able to identify antigens and create antibodies targeted at different antigens. Now, normally it's against foreign antigens such as microbes and other viruses or pathogens. However, on occasion, these cells misidentify something usually on the surface of the cell of the host or the individual as being foreign. And when it does that, it starts to generate antibodies, which will then target and identify cells to be attacked. When this happens to key molecules or cells in the central nervous system, this can trigger dysfunction and a lot of times inflammation and epilepsy. This can also occur through one of the other cell populations in the humoral immune system, including the T cell response, by a very parallel process involving misidentifying host antigens or proteins as foreign, and therefore creating an abnormal response to them by attacking and damaging these cells and creating additional inflammation. So now, identifying autoimmune epilepsy is very important because a lot of times these patients are not responding to traditional medical therapies, including most anti-epileptic drugs. So they often are resistant or refractory. Again, by knowing this, we can do further targeted immunotherapy for these to hopefully improve outcomes and get better seizure control. Often these forms of autoimmune epilepsy also have other neurocognitive complications. So it's an additional impetus to kind of really identify these patients, both pediatric and adult, to avoid any further declines in their cognitive dysfunction. So like I said, often there are targets that we can identify. Most of the time, these are antibodies to proteins on the surface of these neuronal, usually these neurons, where these receptors or proteins are being targeted. Often these patients have focal epilepsy. It's kind of rare for it to be a generalized epilepsy. So that's an additional clue, other than being drug resistant. Sometimes there are other signs of inflammation in the central nervous system. MRI can sometimes detect this inflammation. Other specialized scans, including PET scan, or if clinically warranted in certain patients or during certain types of procedures, biopsy of the tissue can show inflammation as well. Other clues to patients that may have an underlying autoimmune epilepsy or encephalitis is having either a personal history or a strong family history of autoimmune disease. It doesn't necessarily have to be autoimmune disease involving the central nervous system. It could be as innocuous as something as vitiligo or lupus or type 1 diabetes, and can show just the potential to develop autoimmune conditions because there's some inherent defect in the ability for the immune system to recognize what is self and what is foreign, and should be recognized as something to be targeted. Sometimes there's, like I said, some neurological findings, including cognitive decline. Again, there can be multiple seizure types, mostly focal epilepsy, but there can be very many different types of unusual epilepsy, including brachial dystonic epilepsy or abnormal movements that can be identified, or sometimes very unusual psychiatric symptoms, including psychosis, change in speech patterns, and another focal neurological findings like focal weakness or ataxia. Often other causes of epilepsy need to be excluded first, especially ones that are not involving the immune system. And typically these patients present very quickly and peak with their symptoms, usually in a short period of time. Obviously seizures have to have a starting point, but these patients usually have significant progression and significant escalation of therapies that are often not adequately treating their underlying seizures. Now, once you suspect this based on the clinical history, your examination, other diagnostic testing, including neuroimaging, serum and CSF examination, which is usually screening for a lot of these autoantibodies and other signs of inflammation in the central nervous system. You can put this on your differential, again, to the point where you're excluding other medical conditions. Now, it's important to note that in patients who have refractory epilepsy, clinical studies have shown that anywhere between 10 to 20% of those that are refractory have some form of underlying autoimmune epilepsy. So it's not just a rare condition that is not rarely seen in the population of epilepsy. Those that have refractory focal epilepsy, a lot of times temporal lobe epilepsy, you know, a good 1 out of 5 of those patients may have an underlying inflammatory or autoimmune condition. Here, we've listed some of the common, again, acronyms for the molecular targets for these. Most of them are typically surface receptors on neurons in the central nervous system that are key for different functions and transmission from one cell to the next. So when these cells are being targeted and destroyed or triggered, they cause these neurological symptoms, which include majority seizures. Now, this doesn't include all of the possibilities. One that's not I did exclude on here is anti-GAD, so glutamic acid decarboxylase antibodies, or GAD65 is also what is referred to. These antibodies, you know, are seen in other conditions, including other neurological conditions, but can also present in refractory epilepsy. One of the ones that I want to give an example of that is our kind of our prototypical autoimmune epilepsy and encephalitis is NMDA receptor encephalitis. Again, this is a relatively recently described condition, first described in adults in 2007. And the first pediatric patient wasn't identified until 2009. Now, with its increased recognition in the pediatric and adult population, now nearly 4 out of 10 that are diagnosed with this condition are of the pediatric age. Again, like most autoimmune diseases, the overall sex ratio is predominantly female. However, even those that are under the age of 12 or prepubertal, where autoimmune diseases tend to be more equivalent in sex ratio, there's still a little bit predominance, not as much in females. Now, when these children present, they often present with very non-specific symptoms of inflammation and or infection. So these prodromal symptoms usually present very non-specifically, meaning that symptoms that can precede a lot of different conditions, not necessarily autoimmune encephalitis. Those being headache, fever, nausea, vomiting, diarrhea, upper respiratory tract infection symptoms like cough, sneezing, runny nose, congestion. But usually shortly following this, you have what is initial phase of the encephalitis, typically begins in kids, and adults with more psychiatric symptoms. So you see acute changes or sudden changes in behavior, which include new onset anxiety or insomnia, or symptoms of mania, so pressured speech, abnormal thought patterns. A lot of times in kids, you see changes in their speech and language, often either becoming mute or decreased output, or have bizarre sounds, or even more rare things, including some of the things I've seen is like foreign accent syndrome, where the individual starts speaking but coherently, but in a different accent. I've seen one girl who started speaking with a British accent, and she couldn't speak any other way at that point. This usually progresses, and at this point, with non-psychiatric symptoms such as seizures and other abnormal movements or movement disorders. Adults typically present the second part with psychiatric symptoms in 2/3 of the cases. In between, adolescents are kind of in between, the very young and the adults when they present with this. Sometimes in the very young, so which in the toddler ages, sometimes these behavioral changes are hard to identify initially, because a child who's not feeling well with these prodromal symptoms may look like a child who's just irritable or having increasing tantrums. So it may not be identified that it's a true psychiatric syndrome. Identified it initially in the initial patient populations were associated ovarian tumors, which we refer to as immature teratomas. They appear to be the thing that triggers the abnormal immune response, because these abnormal tumors, which are not necessarily malignant, but can cause problems, otherwise, they can develop any tissue type in them. Often isolated in these tumors are hair and teeth and other tissue types. So one of the things that they can develop is these abnormally displayed receptors on the surface of the cells of this tumor, which are not typically anywhere else in the body other than in the brain. And these proteins are on the other side of the blood-brain barrier. So in this very inflammatory tumor, triggering inflammation in the immune system, now seeing something that it normally can't see, it develops the autoantibodies to that target. And then these antibodies can then cross through the blood-brain barrier into the central nervous system and start causing havoc and disruption there. Tumors are not commonly seen in pediatric patients. Less than 10% are seen. Compared to those over 18, about half of women older than the age of 18 will have tumor, which is typically teratoma. It's almost unheard of for males under the age of 18 to have any type of teratoma, like testicular or other location of a teratoma. And it's also girls 12 to 18 can, but prepubertal girls, it's again very rare to see ovarian teratoma associated with an NMDA receptor encephalitis. So now, when these conditions are diagnosed, in addition to appropriately dosed anti-epileptic medications, the targeted therapy then starts to begin place, including modulating the immune system, both in the immediate window and also for long-term treatment. When the initial presentation is identified as being autoimmune, screening for tumors is done to see if they're triggering the abnormal immune response, then they should be removed when possible, or treated appropriately with other measures such as chemotherapy or radiation when not able to be resected. In addition to this, usually first-line immunotherapy would be such things as steroid, often accompanied either with something like IVIG, which is intravenous immunoglobulin, which I'll talk about a little bit shortly, or with a filtration process called plasmapheresis or plasma exchange, which helps filter the circulating blood and filtering out certain proteins, including the abnormal cell components and the abnormal antibodies. Often when there is a good response with that, there has to be some type of form of chronic immunosuppression, because these patients often present with what we call a relapsing course, meaning that despite elimination of any tumors or initial tamping down of the abnormal immune response. If left without any further treatments, the abnormal immune response will often increase again, causing further worsening of symptoms or new symptoms. If these patients don't respond adequately initially to your first-line treatment, second-line immunotherapy is then done, which is obviously a stronger form of immunosuppression, which may have more potential for other secondary side effects, because with suppression of the immune system, it may open you up to other medical conditions, including infection. Another function of the immune system is to monitor for other types of malignancies and abnormal cell responses and keep those in line. So when the immune system is suppressed or stopped in a certain manner, it puts you at increased risk potentially for those, depending on the type of treatment. Initial first-line therapy is usually in the form of glucocorticoids, right? Steroids. There are different types that we often use. IV formulation that can be used most often is methylprednisolone. But dexamethasone can also be used IV. Many of you may be familiar with that because of its use commonly in patients with inflammation related to COVID, especially respiratory inflammation that requires ICU admission and intubation. So it's a commonly used steroid. Other forms include oral steroids, including prednisone, or in the very youngest, prednisolone, which is a liquid preparation. Usually this type of treatments are only given for short periods of time because long-term administration of steroids can cause a lot of potential physical and immune side effects that are very undesirable, including problems with bone density, the GI tract, issues with muscle atrophy, fat redistribution, hypertension, behavioral changes. So usually this is reserved for short courses, typically of, with 5 days or so of treatment, sometimes with a taper, especially as an outpatient, where it's slowly decreased until it's no longer needed. Other forms that are often used both in the initial as first line, but also as subsequent treatment is IVIG, often given intravenously. It's a collection of donor antibodies which can help reduce in many different ways the inflammatory response, help neutralize some of the other autoantibodies, and reduce or eliminate the abnormal inflammatory response. So there's lots of different mechanisms we believe that IVIG has effect on an abnormal immune response, both neurologically and also the rest of the body systems. Again, its use can be limited because it's very expensive. It has to be given intravenously most of the time. So that can limit its use in different locations. But often can be used long-term if necessary, but again, under very kind of stringent infusion protocols. Other treatments that are used usually in the hospital setting is plasmapheresis, is what I talked about before. Typically, it involves having a catheter placed where blood can be taken out of the body in a continuous fashion, obviously not all of it at one time. A portion of it is put through a machine where a filtering process can filter out potential disease components, and then returning the rest of the components back to the individual, which includes blood and other fluids. Typically, this requires many cycles because you can only filter out a portion each time. You can't take out all the blood and filter and put it back in. Obviously, there needs to be a certain significant amount. So you're only filtering out a portion each time. So it usually requires about 5 to 6 cycles. And it's often it's limited. You can't do it back-to-back days because it is pretty hard on the body. And you have to let the body regenerate certain molecules that are filtered out that can't be avoided. Additional targeted therapy. This is more often what we use for chronic treatment of a lot of these autoimmune neurological conditions, such as autoimmune epilepsy and encephalitis. One of them is a medication called rituximab. Trade name is Rituxan. There is a biosimilar generic form of this available as well. It is a kind of a unique concept, meaning that it's a targeted therapy. It's a monoclonal antibody, meaning that all antibodies are identical and they all target a specific protein, which is called CD20, which is on the surface of the B cell immune cells. These are the cells that make the antibodies. So technically it's an antibody that targets antibody producing cells, so it reduces antibodies. So, but it's more of a cruise missile rather than an atomic bomb when it comes to medications that affect the immune system. So only a portion of the immune system is being suppressed. It's FDA approved for a lot of other medical conditions. It has a lot of off-label uses for other autoimmune diseases as well, especially in the pediatric age patients, and has been used very successfully and safely in these patient populations, and is often a medication that often works long-term where other medications cannot. It doesn't typically have too many other medication side effects, such as what happens with steroids or IVIG. Obviously, the main side effect is concern for immunosuppression. Most of the time in kids, we don't see significant opportunistic infections or unusual infections. We see more frequent upper respiratory infections and urinary tract infections, which are usually easily managed but need to be identified a lot of times, especially if they're bacterial. So when we give rituximab, we think these antibodies are attaching to these molecules on the surface, then attaching to these natural killer cells. Their function is basically anything that antibody is attached to, they go in and they destroy, or they cause the cell to say, I'm going to commit suicide. So programmed cell death. There may be some other pathways that are also recently more identified that it may actually work. That often happens with medications. We think we know how it works in one way, but often find out it's working in other ways and maybe more significant ways. So that's often good because it identifies new mechanisms or novel mechanisms that can be targeted by other medications that may have lesser side effects, but it also helps us identify potential unintended side effects long-term. So it's obviously a big topic. It's hard to go over everything within the 30-minute time span. I think I've gone over a little bit here. So I think we'll reserve questions at the end that I can answer for you. And then we'll have you listen to one of my panelists.
Okay, thank you so much, Dr. Williams, for an excellent presentation, fascinating stuff. So we will now welcome Dr. Erin Okazaki, who's an epileptologist from Spectrum Health. Unfortunately, she was not able to be with us today, but she was gracious enough to record her presentation. So we're going to show that now. And then as Dr. Williams mentioned, we'll have time for Q&A afterwards. Thanks.
All right, well, my name is Erin Okazaki, and I am an adult epileptologist at Spectrum Health here in Grand Rapids. And today the topic is inflammation and epilepsy, and I think it's actually very fascinating, and it's a constantly evolving topic. It's exciting in the sense that we're able to have discussions about novel treatment frontiers that previous to 20 years ago were just not in existence. The goal of my presentation and today's talk will be to give a broad overview of how inflammation, specifically neuroinflammation, contributes to epilepsy in the adult patient population, and how our understanding of the pathophysiology has led us to new innovative treatments. So specifically, I'm going to look at traumatic brain injury, stroke, and then a relatively new field of autoimmune epilepsy. So neural inflammation, this is not to be by any means a comprehensive review, but more to just set the stage and contextualize our discussion concerning inflammation. Neuroinflammation is a very normal response that the central nervous system has to various insults. For instance, trauma, infection, stress, you name it. The inflammatory response is a finely orchestrated maneuver between many different proteins and cells in the central nervous system. But of interest in today's talk are these glial cells that are found in the central nervous system. There are 5 types. They come in 5 flavors: astrocytes, oligodendrocytes, microglia, ependymal cells, and radioglia. Some of them are seen in the peripheral nervous system as well. But specific to neuroinflammation, I'd like to focus on 2 types: astrocytes and microglia. So microglia, again, are part of kind of this innate immune response, and they produce a real active immediate response to injury. And when we see acute inflammation, especially in the brain, it's believed to be mediated in part by this rapid kind of activation of the microglia. Astrocytes, on the other hand, are perhaps the most common glial cell type that's found in the central nervous system, and they provide a variety of functions. They maintain the blood-brain barrier, which is kind of this semi-permeable collection of cells that acts as a protective barrier around the brain. The astrocytes also kind of regulate blood flow, what goes in, what goes out of this barrier. They also maintain and support neurons, so they help really maintain this kind of homeostatic metabolism and state of cell maintenance. So very important to the immune response. And then just a quick word on cytokines. These are proteins, and they activate different signaling relays to direct immune cells to any particular area of interest within the brain. So moving on to neuroinflammation and seizures. In the normal central nervous system inflammatory response, that homeostasis is maintained, and it's maintained when, of course, you're balancing all these other demands that are placed on the central nervous system when it needs to make changes and repair damage or combat infection. If that steady state is disrupted over time, these aberrancies can result in damage, and the prolonged altered activity of the cells can be detrimental. So due to kind of an interconnection and kind of intricacies of various immune pathways in our bodies, we can see that damage can occur from both within the central nervous system or with also help from external mediators to the CNS. So in general, it is recognized that seizures are manifest in both inflammatory disorders that originate primarily in the central nervous system, as well as other broad systemic conditions. So these are just a couple examples of that, where we can see here inflammatory disorders of the central nervous system can be accompanied and manifest with seizures that are at a greater prevalence in the general population. We see this in multiple sclerosis. We see this in ADEM, or acute disseminated encephalomyelitis. We can also see this in the setting of primary CNS vasculitis, when the vessels of the central nervous system become inflamed. Seizures in those situations can occur in approximately 1/5 of patients. On the flip side of that, we can see systemic disorders, so things that are not necessarily originating within the central nervous system, but have influence in a way that we do see a increased prevalence of seizures. Examples of those would include like systemic lupus, erythematosus, Sjögren's syndrome, and sarcoidosis. It's postulated that this is multifactorial and may include one or several downstream effects kind of arising from a mix of metabolic disturbances, inflammation in the central nervous system, and neuronally directed antibodies. So now, given the observation that there is some link between neuroinflammation and seizures, I want to turn our focus now to a couple of the specific topics. The first of which we'll look at is traumatic brain injury. So with traumatic brain injury, you have immediate damage or trauma. So there is something that exerts some sort of blunt or penetrative force and it crushes the skull or damages the tissue, basically you end up with a some sort of alteration in the structure of the brain. A secondary injury occurs immediately after this initial insult, and the consequences can be of variable persistence. Oftentimes depends on the severity of the injury or the type of injury. So the neuroinflammatory response happens during this secondary phase. And again, we're still studying kind of the process, but it is thought to be related to this persistent upregulated immune response, which we kind of touched on a little bit earlier. And then over time, it's creating more, it's creating these aberrant downstream pathways that lead to increased neuron excitability and ultimately resulting in seizures. So as such, the neuroinflammatory response is of particular interest as a potential therapeutic target. Overall, the incidence of post-traumatic seizures is about up to 10%, and depending on the study, there have also been reports of specific groups of patients that suffer from traumatic brain injuries that have, say, skull fractures, or they have large blood clots that require surgical removal. In those cases, the incidence can be of these early post-traumatic seizures can be up to 1 in 4, so about 25%. Of those individuals that go on to develop post-traumatic epilepsy, just under half will have their first seizure onset by 6 months, and that increasing increasing a little bit higher as we move out to like the year mark. But in general, when we're looking at the severity of head injuries, the longer the patient is at risk, the worse the head injury, the longer the patient is at risk for late seizures, again, in general. Now, some patients will have seizures that are difficult to treat, seizures that keep occurring despite multiple medications, and given the population of patients that do demonstrate resistance to treatment, there is always interest in new mechanisms and possible targets. So looking a little bit closer at neural inflammation, it's not only of interest as a contributor to epileptogenicity, but also due to the fact that seizures themselves can beget inflammation. So when we look specifically at the neuroinflammation, we can see that within hours of injury, you get this like flood of cytokine release, and this can continue for a while, and it will ultimately impact downstream activation and modulation of receptors that ultimately contribute to the immune response. So not only do you have local activation of the immune cells, but you can eventually get peripheral immune cells that are recruited into this process as well. And this can be ongoing. And ultimately, you're going to end up with cell loss. So there is some research that looks at kind of broad target antigens, progesterone, minocycline, things like that, to reduce neural inflammation after traumatic brain injury. But the clinical trial data looking at this is very short run, and has not supported benefit. Other considerations include kind of the neural protective benefits of hypothermia, which is used again, in the acute phase. But subsequent trials really haven't suggested a robust impact on epileptogenesis. So currently, moderate to severe traumatic brain injury patients, anti-seizure prophylaxis is used for approximately the first 7 days. But the understanding of the mechanisms, the understanding of what eventually transpires into epileptogenesis is still ongoing. Current research suggests that there might be some specific pro-inflammatory cytokines, and these are within the IL-1 family, and they produce downstream responses that result in the development of post-traumatic epilepsy. Additionally, there's research looking at other proteins. So this HMG B1, or the high mobility group box protein 1. After injury, this particular protein can be released from the cell nucleus and can facilitate and perpetuate inflammation. So in the future, it might be that these proteins and cytokines might be potential targets for treatment of post-traumatic inflammation as it relates specifically to post-traumatic epilepsy. So now switching gears a little bit more, let's kind of take an overview and look at a different type of brain trauma here. This is post-stroke seizures. So seizures are a very common complication after stroke. We often see kind of this bimodal distribution. They peak on the first day, and then you can have another peak about 6 to 12 months later. Again, very, very common. There was a population-based study that was done in Rochester, Minnesota by Hauser and his colleagues. And basically they saw that population data suggested post-stroke epilepsy accounted for 11% of all epilepsy cases, and post-stroke epilepsy accounted for 45% of the cases in adults over the age 60. So a pretty significant amount. When we talk about seizures that occur after strokes, we also want to know kind of who is at the highest risk, who's at the most risk for developing these seizures. And it often depends on multiple variables, including stroke type, where's the location of the stroke, how large is the stroke, and the degree of neurologic deficit. There have been some predictive models that have recently been looked at. One model looking specifically at developing a post-stroke epilepsy risk scale took 264 patients, consecutive patients with stroke, and assessed their post-stroke epilepsy risk at 1 year. They basically looked at 7 factors: the location of the stroke, if there was a hemorrhage involved, where the ischemia was involved, if there was ongoing neurologic deficit, when did their seizures occur? Did they occur 2 weeks after the insult, or did they occur after that 2-week mark? And basically put together a rating scale. Similarly, other scales have been developed. There's one that looks specifically at intracerebral hemorrhage, which is called the CAVE score. Basically, CAVE stands for cortical location, the age of the patient, the volume of the hemorrhage, and if they developed early seizures. And in that particular score, saw that risk increased to 46% if you had a score of 4. So, definitely different modalities have been used in trying to kind of predict who might be most at risk. When we do talk about seizures that occur after stroke, we put them in one of 2 categories. We'll put them in either early or late seizure category, depending on their timing of occurrence. So though the exact duration of what constitutes an early post-stroke seizure can vary, especially with research and in the literature, typically we're looking at a 1 to 2 week period, typically 1 week post-insult. In contrast, late post-stroke seizures can occur from the 2-week mark and beyond. Approximately 10 to 15% of patients after stroke will present with early onset seizures and then go on to continue to have seizures thereafter. The pathogenesis really is a little bit different. Early seizures, it's more a consequence of ischemia, where you have increased extracellular concentrations of glutamic acid, and then downstream effects of that result in excitotoxicity, leading to cell damage. You can also see just Erupted ion channel dysfunction, disruption of the blood-brain barrier. These have also been kind of implicated in those early seizures. Late post-stroke seizures are more a consequence of this long-term damage. Again, kind of what we saw with the traumatic brain injury of chronic inflammation here in this particular case, which strokes results in scarring. You end up with altered cell relay functions, and that creates foci of cortical irritability and aberrant neuronal function. So post-stroke seizures, when we talk about treatment, there have been several studies done, and I'm going to look specifically, I'm looking specifically here on the older population. And in general, they've looked at monotherapy with carbamazepine, levetiracetam, phenytoin, zonisamide. And ultimately, the conclusion, especially when we're looking at the older population, is that they do better with newer generation anti-seizure medicines than older generation anti-seizure medicines. At the end of the day, though, when you're tailoring treatment, it really needs to be tailored to the patient. And especially in older populations where we're looking at medical comorbidities such as liver and kidney function, we need to be kind of careful with regards to drug selection based on the way the drugs are metabolized, how they are excreted, their interactions with other medications. The other thing is cost should be taken into account. A lot of medications could be cost prohibitive for certain patient populations. When it comes to other non-anti research regarding other non-anti-seizure medication derivatives, statins have come up in the literature. Basically, statin inhibits the function of the HMG-CoA enzyme. And usually it's used to manage cholesterol, but the effects are also being used to see how it works in epilepsy for possible neuroprotection. There's a potential anti-inflammatory effect via decreasing pro-inflammatory cytokines. There's a potential anticonvulsant activity. It's hypothesized to stimulate GABAergic activity, and in the end, decreasing the expression of certain pro-inflammatory genes that could relate to, which could contribute to epileptogenesis. So, anticonvulsant prophylaxis is not always indicated with stroke, but statin use is definitely recommended for secondary stroke prevention. Not particularly for seizure, but this definitely remains of treatment interest going forward. So switching gears to our third kind of a topic of this presentation, I just want to touch base a little bit with autoimmune epilepsy. And basically here we're looking at how the body's immune system has changed in the way that it functions. And we're dealing with epilepsy driven either by an autoimmune or a paraneoplastic cause. And when I say paraneoplastic, I mean an antibody that's associated with an underlying cancer, whereby the antigen is seen in both the cancer cells as well as normal cells, and then that becomes a target for the antibody. This is an area that's of growing interest in epilepsy, especially in patients that have medically refractory epilepsy, where the cause of their seizures is not known. Because if autoimmune epilepsy is identified, patients typically show responsiveness to medications that are not your traditional anti-seizure medications, and they show response to immunotherapies. So the earliest descriptions of a link between an autoimmune process and the central nervous system was initially presented in the case report back in the 1960s, and detailing basically Hashimoto's encephalopathy. Today we know it more as SREAT, or steroid responsive encephalopathy, associated with autoimmune thyroiditis. But that was really the first time where there was this link that was kind of brought up between autoimmunity and its effect on the CNS. Soon thereafter, we saw more case reports of what is now become known as limbic encephalitis. And they were documenting cancer patients that exhibited cognitive decline, seizures, and behavioral changes. Later on, as we have grown in our knowledge, limbic encephalitis is also noted in other clinical scenarios, so not always related to cancer. But this kind of ushered in this identification of specific antibodies starting in the 1980s. And since the 2000s, we've been able to learn about many different biomarkers. This is not an all-inclusive list, but the different antibodies and markers are in white on the right side of the page. So when it comes to autoimmune epilepsy, we're looking at antibodies that are directed towards an antigen either on the surface of the cell or within the cell. So generally speaking, antibodies to intracellular antigens might have a higher association with cancer versus antibodies on the surface, to neuronal surface antigens have a more variable association. And oftentimes can show maybe a little bit more robust response to immunotherapy. Common antigens that have been looked at in the literature are listed here below. Limbic encephalitis is associated with LGI1 and oftentimes has a very specific presentation with cognitive decline. You often have these very specific types of seizures called facial brachiodystonic seizures, where you have involuntary movements of the face and the arm. It's also accompanied by hyponatremia or low sodium, and as well as some sleep behavior disorders. NMDA receptor encephalitis is kind of characterized by behavioral changes, hallucinations, psychosis, seizures, memory impairments. Some people can have movement issues like catatonia. There can be instability in the autonomic nervous system. You can have mouth and facial kind of movements. In extreme cases, people can present with coma. Other common antigens that are located intracellularly are also listed below. And in these cases, we can see a variety of clinical manifestations, ranging from sensory neuropathy to widespread nervous system involvement, abnormal movements, as well as basically inflammation of different parts of the brain and the brainstem, depending on the type of antibody. So just in general, there are many clinical things to look out for. There's a wide variety of symptoms, everything from memory deficits, psychiatric symptoms, movement disorders, disorders of the autonomic nervous system, patients that present with very high seizure burdens at the very beginning of their course or with status epilepticus should also raise red flags. Also, patients that have resistance to typical seizure medications very early on should also raise red flags, as well as a family or a personal history of autoimmunity or cancer. So when it comes to the workup, we're looking for very specific things. We will look first in the serum. We're looking for antibodies, so we can send off specific panels that are looking for these antibodies. We're also looking for markers of inflammation. So something like a sedimentation rate or a CRP or thyroid testing are typically done. We will also get spinal fluid. Here we're looking for any, again, markers of inflammation that can include increased protein, oligoclonal bands, IgG index. We can also see sometimes an increase in lymphocytes. And we also are looking for the same kind of battery of antibodies with specific antibody panels. EEG is helpful. It can show us if there's any sort of misfires or cortical irritability. or seizures, and where the seizures are coming from. MRI of the brain is helpful because we are looking for changes in specific areas of the brain, particularly the temporal lobe. But of course, that is not exclusive. And we can also see other changes that include multifocal lesions as well. The PET scan of the brain looks for possible metabolism changes in glucose. We can see that there might be hyper or hypometabolism in the area of interest or the affected areas. Certainly too, cancer screening and further testing with ultrasounds, ovarian testicular ultrasounds, or thoracic, abdominal pelvis CTs, or full body PET scans will also be helpful, especially given the high incidence of these antibodies and their relation to cancer. So there have been some proposed scoring systems to help guide diagnostic testing, because the testing is often extensive and takes time and can also be quite expensive. The caveat to this is if you have a high clinical suspicion, you would go ahead and treat somebody. But there's one particular scoring system, the APE score, looking at the antibody prevalence in epilepsy of unknown etiology. Basically, they're looking at different features, and each of these features are assigned a point value, and there's a total of 15 points. A score greater than 4 typically predicts a high likelihood of autoimmune disease. So again, autonomic dysfunction, we're looking at imaging findings, any sort of new onset seizure, or rapidly progressive cognitive changes in like a 1 to 6 week period. We're looking for inflammatory changes in the spinal fluid. We're looking for, again, those very kind of specific seizures. We're looking for any sort of cancers, also take into account psychiatric symptoms, medically refractory seizures, so the ones that are not responsive to medication, and multiple trials of medications, as well as any sort of viral prodrome that might have occurred prior to this. When it comes to treatment, there have also been the development of, basically it's an extension of the APE score, and has resulted in the development of a RIGHT score, or the response to immunotherapy in epilepsy. And this portion of the predictive model is to help determine a response to immunotherapy. So the RIGHT score is basically the APE model, as well as the addition of 2 variables: the initiation of immunotherapy within 6 months of symptom onset and detection of neuroplasma membrane antibodies. Basically, a score of greater or equal to 7 out of now a total of 19 would predict a potential response to initial immunotherapy with autoimmune epilepsy. The goal of treatment is always here to reduce the amount of ongoing damage. As time goes on and as the disease gets under control, the goal of therapy becomes more of maintenance, and you want to prevent disease progression or any disease relapse. So in terms of treatment, there are several different modalities that are available and that have been studied. At this point in time, though, we don't have any at this point in time, we don't have any truly tested algorithm to follow. However, anecdotal evidence and clinical experience has supported the use of these treatments, as well as emerging research for the use of these treatments with specific antibodies. First line, typically corticosteroid therapy and IVIG. Corticosteroid therapy in the form of methylprednisolone basically works by binding to intracellular receptors to decrease the production of genes that encode pro-inflammatory cytokines. There's also some added benefit with possible blood-brain barrier restoration and then the improvement of edema. IVIG, on the other hand, is basically administered through an IV, and it is a collection, basically a pool of blood products from many different donors, thereby providing kind of a passive immunity with antibodies to numerous different antigens. Plex or plasma exchange removes the autoantibodies. It effectively kind of changes the composition of the immune system, specifically with regards to T cells. So after these therapies, patients are assessed for response after each course of treatment. We expect that within about 6 weeks, we should see a reduction in seizure frequency. Though ultimately the improvement of more of the neuropsychiatric symptoms can take much, much longer. When somebody does have complete or partial sustained response to treatment, that opens up considerations for other immunosuppressive therapies listed here. So myclophenolate mofetil and azathioprine are often used in conjunction with IVIG or steroid therapy and then continued on as monotherapy. Rituximab is interesting. It decreases the B cells, which is a type of lymphocyte that's part of the body's immune response, and it targets a very specific protein on the cell surface called the CD20. This may have increased effectiveness in cases where the antibody is located on the cell surface. Cyclophosphamide, on the other hand, is a little bit more broad. It inhibits cell proliferation and targets the B and the T cells. Cyclophosphamide is sometimes considered more for those antibodies that are located intracellularly. So again, multiple different novel approaches to an autoimmune cause or a paraneoplastic cause in cases that manifest as medically refractory epilepsy. Again, though, there's emphasis that I want to say everything needs to be taken into context as a whole picture when looking specifically at autoimmune epilepsies. And, really the importance of obtaining a complete and a complete evaluation, looking at the clinical picture, the ancillary findings, EEG, MRI, CSF, serum, as well as treatment response, are very, very key in identifying this sort of epilepsy. So to conclude, neuroinflammation in epilepsy continues to be an exciting and a very dynamic field. Again, this talk was to provide just a very, very broad overview of how inflammation, specifically neuroinflammation, contributes to adult epilepsy in the setting of traumatic brain injury, stroke, and autoimmune epilepsy. As we increase our understanding of how these mechanisms of inflammation play a role in pathogenesis, I think we are going to be able to provide even more novel approaches, not only to treatment, but to diagnosis as well. So again, a very interesting and dynamic topic. So with that, I want to thank you for having me and wish you all a good evening. Thank you.
Okay, thank you, Dr. Okazaki. So one question regarding infantile spasms is, what is your recommendation for treatment of infantile spasms after one course of ACTH and vigabatrin have been tried, but hypsarrhythmia and spasms persist? And maybe just talk also about that decision between ACTH, which does address inflammation, and vigabatrin, which I'm not sure whether it does.
So when we're looking at patients who are refractory to our first and second line therapies, which ACTH is usually for most centers thought of as the first line therapy, there may be some limitations on why it's not chosen first, versus vigabatrin, which again has its pros and cons. So they each have potentials to obtain remission of the infantile spasms and normalization of the hips arrhythmia on the EEG. Usually ACTH is thought to have a higher success rate, depending on the study you look for, is between 70 and 80%, whereas vigabatrin, non-tuberous sclerosis complex patients, it's between 60 to 70%. In TSC patients, it's over 95%. So it's usually the treatment of choice for infantile spasms in tuberous sclerosis patients. As far as when you have treatment failure of both of them, I would, re-examine with your neurologist the ACTH, the relative dosing parameters. There are certain protocols that are thought to be in the moderate or high dose range. If an individual fails but had a partial response to a moderate dose range, you may reconsider the pros and cons and the risks of doing a high dose protocol of 6 to 8 weeks of the ACTH. Other options include looking to see if there is a focal onset for these epileptic spasms. In the past, it had been thought that these were a generalized form of seizure, but we know in anywhere from 15 to 20% of cases, there is a focus that seems to generate the abnormal response between the cortex and the thalamus. Some of those patients, if you can identify, they may be actually surgical candidates. Your best bet is to be evaluated at a center that can do that evaluation in pediatric patients. Usually it involves doing a form of PET scan, an FDG PET scan, which is a functional neuroimaging tool that looks at patterns of activity in the brain, including the cortex and the deep structures. And then working with the epileptologist that may work with the epilepsy surgery team to see if there is a focus that may be that individual may be a candidate.
Okay, a few just kind of various diseases that are mentioned as possible, or can they be connected to the development of epilepsy? One is Lyme disease, Epstein-Barr, and Crohn's disease, all of which can involve inflammation. For those three, just as examples, are any connection between those and possible development of epilepsy?
There's a lot of data that does link higher rates of epilepsy in patients with Crohn's disease and other forms of inflammatory bowel disease. The exact mechanisms, it's not completely known, but there's higher rates of other inflammatory autoimmune diseases of the central nervous system in like Crohn's disease, including demyelinating diseases like multiple sclerosis or autoimmune forms of peripheral neuropathies. So it may just speak to the individual having higher amounts of inflammation systemically, maybe higher rates of developing other potential inflammatory disorders along with it. It may point to more of genetic risk factors for inflammation and autoimmune disease. As far as Lyme disease, Lyme disease can be associated with epilepsy, definitely, where there's neurological manifestation of a systemic Lyme infection. It's not often, and in those who already have epilepsy, it's definitely like any other infection can lower the threshold. But it's not classically systemic Lyme disease without CNS involvement is not usually associated with any forms of epilepsy or traditionally autoimmune. Epstein-Barr virus, virus that most, probably over 80% of people are exposed to by the time they're 50 and have evidence that their immune system has attacked it at some point. And it's a type of viral infection that often is one of those ones that actually goes dormant in nervous tissue. So usually we only see it when the immune system is really suppressed, and rarely as a central nervous system complication. Usually it's just there. It's a kind of a byproduct of a suppressed immune system. Again, like any acute infections, if it's a first-time infection, especially for kids, again, any infection has potential to trigger in already those who are established as epileptic. It lowers the seizure threshold, so can cause seizures. Same thing with other forms of viruses that specifically that can have effects on the central nervous system as well. Unless there's direct damage to the central nervous system, which some of those don't usually cause. Usually they're more of a triggering in those who already have epilepsy, usually due to other factors.
Okay, great. Thank you so much, Dr. Williams and Dr. Okazaki, for a great presentation on a very complex and fascinating topic.